great to be back in Israel. I guess I also saw Laurence and Zahava and other people here about 4 years ago when the International Skeletal Society was in Eilat. And so today what I thought would be a good thing is to, with a half an hour, go over anterior shoulder instability, not the whole thing about shoulder instability. We just would be glossing over a lot of things. So here you can see a picture that you don't usually see when the patient comes in, a totally dislocated shoulder anteriorly. And so we will talk about that because we are mainly focusing on trauma. But we have to remember that there's a very wide spectrum of shoulder instability. And this includes the acute dislocations that we see very frequently, usually in the younger patients. Chronic instability with repeated dislocation is another thing that we see all the time. People just dislocating, and those are the ones that you really want to address. Why are they continuing to dislocate? Do they need surgery? And then we have those with chronic instability, but they aren't dislocating, and that's more complicated. I'm not really going to talk about it, but micro instability is one of them, where your shoulder kind of rocks back and forth, and there are lots of impingement syndromes associated with that. And when we have remote trauma, overuse of the shoulder, or laxity of the capsule, we can have the things that aren't the classic anterior or posterior dislocation lesions. So let's start with some anatomy here. We have a picture of the glenoid en face, and we have in red the rotator cuff muscles and tendons, and we also have the biceps tendon. And then in yellow we have the glenohumeral ligaments, and these are very important structures to hold that glenohumeral joint together. The dynamic stabilizers are the muscles and tendons, so the rotator cuff is a dynamic stabilizer, and the long head of the biceps. Passive stabilizers are the bones, including the glenoid rim and the glenoid itself and the labrum, and also these capsulo-ligamentous structures. So we have our superior glenohumeral ligament, middle glenohumeral ligament, and then we have the inferior glenohumeral ligament, like a hammock on the inferior aspect, which is very important for anterior instability. When we talk about the labrum itself, we have different locations for different kinds of problems. And at the top, we have the superior portion, where if you're young and you have problems with your shoulder, it's usually something like a slap lesion, a tear in the superior area, which may or may not extend around. Then we have anterosuperior, and we're going to see that both of these locations are frequent for normal variants, and we don't want to overcall the tears in those locations. And so this is the front. We have the middle right there, the equator, and below the equator, the antero-inferior portion, where a lot of the anterior dislocation instability is formed, and we have our labral lesions here. Less commonly, they go inferiorly, and then postero-inferior and postero-superior, often with multi-directional instability, posterior instability. We also talk about the labrum as a clock face, with the topping 12, the front of the equator 3, 6 o'clock on the bottom, and 9 o'clock in the back. So we will refer to that. Some people put that in their report. I think mainly it's important to describe where your lesions are located, either using a clock face or just the different segments and where they go around to. Now here we see our labrum attached to hyaline cartilage and the glenoid, and it's fibrous connective tissue. It deepens the glenoid fossa, providing more stability, and it's not always low signal like we see here. This is a T1 weighted fat suppressed MR arthrogram, and they're beautiful kind of rounded or triangular structures here. Not always, especially as we age. We get ossification, synovialization. It starts to atrophy a little. Those are okay, but you don't really want to see high signal in the labrum, morphologic distortion, where it's very irregular. And we do have a lot of normal variants, mostly in the superior and the anterosuperior portion. we're not going to really talk about the sublabral recess where it is superior, and we're not really addressing the difference between a slap lesion up here and a variant. We're going to focus more on the anterosuperior area, where we have two main variants. One is the sublabral foramen, where the labrum is lifted off of the glenoid and there's a little hole right there. And sometimes the middle glenohumeral ligament will be larger than usual in this variant, not always though. And we do see this extremely frequently. Up to 20% of shoulders will have it, so it's very important to know about. Usually it goes down to the equator, 3 o'clock, but it has been shown sometimes it can go even below the equator. So this is what it looks like. If you're at the top on the axial view, you'll see that the labrum is separated from the glenoid down to the middle of the shoulder, where then it becomes normal, and you don't want to overcall this a tear. One of the things that can help you is to follow down to the equator, and you'll see this little periosteal attachment called a labral slip, which puts it back onto the glenoid, and it's very smooth at the bottom, and if it's isolated right here, then you can say that's most likely a sublabral foramen and not a tear. If you see that there's a tear below or above the sublabral foramen, you can't always be sure if it's just a normal variant or a tear. And they have shown that some people with sublabral foramen do have slap lesions more commonly. So maybe there's some sort of association with not having a fully attached labrum and getting stress in different locations with a little bit of stress on the shoulder. Now sometimes, and we saw this for many years, but didn't really know what it was until I heard Jenny Bankart talk about it from NYU. You can get this fluid that kind of gets constricted through the sublabral foramen, and it goes into this area that's called the subscapular recess. It looks like a cyst. And you know, we always think when you have a cyst near the glenoid that it's a labral tear. So in this case, if it's isolated up here and you don't see anything else in the glenoid area, just accept that it's probably just a normal sublabral foramen cyst. So that's the axial view of it. This is what it might look like on sagittal, where you see this little cyst kind of in the anterosuperior area next to the labrum. Of course, if there were a slap lesion, those cysts can be in that location, so make sure that you don't have a slap lesion up there. And it's a nice thing to know about, so you don't overcall it. The other thing that happens up here is the Buford complex, where you don't have any anterior superior labrum at all. And this is less common than the sublabral foramen. Mostly these are associated with a very large middle glenohumeral ligament, a cord-like middle glenohumeral ligament. And it looks like this on the cadaveric specimen, where you have the biceps at the top, the back of the labrum is here, and anteriorly there's no labrum at all, and this is that cord-like middle glenohumeral ligament, usually starting from the superior glenohumeral ligament or biceps and going down to the subscapularis tendon and muscle, and then going to the lesser tuberosity. So very classic. The problem with this, again, is that it can be mistaken for a labral tear if you don't know about it. And you'll see that there's no labrum on the glenoid. There is this very round structure, which you might mistake for a labrum, but it is the middle glenohumeral ligament. And then at the equator, the labrum looks normal again. So here we have another one. Don't call that a labrum. Follow it down. Look at the sagittal. You'll see that that big fat thing is just a middle glenohumeral ligament that parallels the glenoid, and that this patient does not have any anterior superior labrum, but it reconstitutes about 3 o'clock most of the time, and so that's a normal variant. Now what we're going to do is focus on the tears that we get of the labrum and the ligaments in the inferior segment when we have anterior instability. And it is like an alphabet soup sometimes when we think about all the different things that might be present. First of all, the labral tears. And I want to make sure that we are familiar with these very classic ones, but you could just get a little tear that wouldn't be a Bankart, a Perthes, or an ALPSA. And the main thing is to describe your tears. You don't have to memorize these. But we frequently see these different types that are often isolated antero-inferior labral tears, but they can be associated with other tears around the glenoid in the labrum. Now, the other things that you're going to see, and these could be even more important in some respects, are the inferior glenohumeral ligament, thinking about the anterior band, the ALIPSA, the GAGL, the HAGL, the BAGL, and the FLAGL. So we're not going to memorize all those, but as you can see, you got that alphabet soup, and that's, I know the American orthopedic surgeons like to do this, so they kind of torture us with all those alphabetical phrases. So let's look at what we're going to be talking about. On the antero-inferior glenoid, where the yellow X is, we have the antero-inferior labrum. So you're going to get a Bankart, labral tear, or a variant of the Bankart, such as a Perthes or an ALPSA. You can also get a tear that is associated with a cartilage abnormality adjacent to the labrum called a GAGL lesion. Sometimes with instability, sometimes just from adduction and internal rotation of your shoulder when the humerus hits the glenoid. And then the ligament, the anterior band, which we see here, the inferior glenohumeral ligament that goes from the glenoid to the humerus, that can be stripped or it can be avulsed, and that's a pretty important problem when you get an avulsion of the anterior band of the inferior glenohumeral ligament. That's called ALIPSA or GAGL. Now we're going over to the humeral side, the anterior neck of the humerus, and there you can get the GAGL lesion where you get an avulsion of the anterior band of the inferior glenohumeral ligament from the humeral side. You can get a bony avulsion, which is a BHAGL lesion. You can get also the FLAGL or floating AGL, where it's torn at both sides. So we have the X on the yellow and the white. If this tears off on both sides, then it's extremely unstable. And it can go from the anterior band, sometimes to the axillary pouch and even the posterior band. It's important to say where you see the ligament not attached to the bone anymore. So now let's look at those labral injuries associated with anterior instability. We have a little diagram here. I hope you can see pretty well up there. But we'll go over this in detail, that you can have an avulsed labrum, just a labrum, with the scapular periosteum no longer attached to the glenoid. That's a Bankart. The Perthes is when it's still attached to the glenoid and sitting on top of the glenoid. And then the ALPSA is when your labrum balls up medially to the glenoid, but still attached to scapular periosteum. So here's a Bankart lesion. A normal labrum is usually attached to the glenoid with cartilage at its base and a scapular periosteum that's intact. And when you have an anterior dislocation, sometimes it just avulses off, and so does the periosteum. And it can go anywhere, that labrum. It can float even way up high in the rotator interval area. And this is what it would look like if it were close to the glenoid, but not there. You can just see a nice triangle separated from the inferior glenoid, and there's no periosteal attachment. So we call that the Bankart lesion, the soft tissue Bankart. The one that's a real problem to diagnose is a Perthes lesion, because there is still a scapular periosteal attachment, and the labrum stays very close to the glenoid. So sometimes you don't even see that it's separated, and there are certain things that you can do to bring it out, like the ABER position, which we'll talk about, to pull it off of the glenoid. Otherwise, you might miss this tear. And here we can see when I did the ABER that there is fluid contrast getting into the base of the labrum. This is the inferior glenohumeral ligament being pulled in this position, and then we are able to make that diagnosis. And when they go in with the scope, they're able to see the tear and put it back onto the glenoid. The other version of this Bankart lesion is when it balls up medial to the glenoid, but is still attached to the scapular periosteum. It has the name ALPSA lesion, which stands for Anterior Labral Ligamentous Periosteal Sleeve Avulsion. And these can be acute or chronic. And the main thing is to describe that they're more medial. Like this one, it's not on top of the glenoid, it's this little ball of black medial to it, and you can see that it's retracted from the glenoid rib. You can have an acute ALPSA, like this one. So the labrum is medially retracted, but it's skinny and small. And here on the ABER, you can see it again. And then you can have something like this chronic one, where it acts like a pearl and you get synovial tissue around it and eventually it goes back up to the glenoid, but it's a big black mass. That means there's been a tear there. And it might be hard for them to see with the scope. There's a little crease right here, but if you just put a scope right there, you might not notice that there's a tear. The MR can be very helpful to show those too. So here we have an interesting follow-up on this case, because that's a Perthes lesion right there. There's a little crack right there. It's still attached to scapular periosteum. The labrum is up at the glenoid rim. And then we saw this patient a few years later, and these are both ABER position. And you can see how the labrum retracted medially. So you can go from a Perthes to an ALPSA to a Bankart in the same patient. It's mainly describing where it's located. Is it still attached to scapular periosteum? There are varying camps about should you do ABER or not. We usually do it in those younger patients who have instability. We do it at the end of the study, and we do it when we do MR arthrography, which is often for the young patients with instability. Although if you've just dislocated your shoulder within a week or two, you may not have to put contrast in the joint because there's a lot of fluid there in most patients already. But this is a nice thing to do. So put the arm behind the head. There are various ways that you can put coils in the axillary region, and then you can get views, which I'll show you in a second. What are some advantages? Well, one of them that people don't think about all the time is that it can show micro instability of the shoulder. Like this patient who looks normally aligned with the arm at the side, but when they do ABER, their humerus moves forward anteriorly, so they're unstable. And you brought that out by doing ABER. That could be important. They might want to, fix the capsule or something. The technologists need to be aware of how to get the ABER images. You get a coronal scout of the humerus, and then you do your long axis along the shaft. And that gives you these oblique axial images that go through the glenoid rim and along the undersurface of the supraspinatus and infraspinatus tendons. From top to bottom, the way to get oriented is to see that the biceps is at the top, and you're going to see the Anterosuperior Segment and the Periosteal Segment at the top. And then as you go down, you're going to pick up your Inferior labral tears that we're talking about. So here we see the biceps, and we can see slap lesions on these as well, the superior labral tears. This is normal. The undersurface of the supraspinatus is smooth. It also shows us our articular side. It tears the rotator cuff very nicely. It pushes fluid into the articular side. So when you see contrast in there, you know you have a tear. And here we see we're getting more inferior, so we're seeing the mid labrum, the undersurface of the supraspinatus, and then at the bottom is where the Perthes lesions will stand out, the Bankart's in front, the inferior glenohumeral ligament tears, and then the infraspinatus tendon at the bottom. So here's a case of a Perthes lesion where you really don't see it with the arm at the side, even if you do MR arthrography. But if you do the ABER, then you can see the contrast getting into the base of the anterior inferior labrum. And so that's important. They did a whole paper on Perthes and how MR arthrography wasn't that good for Perthes lesion, but they never did the ABER in that paper. That was the Wordler paper. The other lesion that you're going to see down here with the labrum is when you have a labral tear, but you also have cartilage loss. And you want to always mention if you see cartilage loss. And if it's close to that labral tear, we call it glenoid labral articular disruption. We can see these with anterior instability, but they sometimes occur without it, sometimes with forced adduction, and when the humeral head hits the glenoid without instability. And it's bad because you have cartilage loss, you get arthritis, you get bodies in the joint. And here are some examples where you look at the base of the labrum and the cartilage is not normal. There's a little tear of the anterior labrum. Here's another one where you see that loss of the cartilage. And one other thing I've noticed when we do ABER is that we see cartilage lesions even better on the glenohumeral surface. So sometimes that's a good thing to look for. Now, what do they do with all this information? If the person is having problems and if they think that the labrum is unstable, if it's separated from the glenoid, then they'll put little suture anchors in, the Bankart repair, and they can be metal or they can be bioabsorbable or just plastic. And when you're looking at radiographs, you may not see them at all. If you look at this radiograph here, the green arrow is pointing to a few areas that almost look like cysts, but they're the post-op tracts of the suture anchors. And here you can see that most of these tears are from the 3 o'clock position to the 5 o'clock position. And so in the United States, most of the time they'll put suture anchors, there are 3 of them, from 3 to 5 o'clock, very classic location to repair the labrum. And so here's a labrum that they repaired with those suture anchors. They do it arthroscopically, and on MR, you're going to see the little tracts in the anterior glenoid, even if they just look like cysts on x-ray, and you see them very nicely. The labrum itself might be blunted, but it usually does not have contrast going inside. Otherwise, you've got a re-tear, or if it's like displaced, you want to mention that. Now, the inferior glenohumeral ligament also is very important to look at, especially the anterior band. And this is a little bit unusual, but sometimes it just strips medial to the glenoid rim, like this one. And they call that anterior ligamentous periosteal sleeve avulsion, and ALIPSA is the term for that. Now, the thing is that some of us actually might have a normal inferior glenohumeral ligament that's more medially located, so you can't always be sure that that's a true lesion, and it's probably not as significant as if you have an avulsion at the glenoid rim like this. And this is much less common than a humeral avulsion. It's called the glenoid avulsion of the inferior glenohumeral ligament, or a GAGL lesion. But it is important to pick up. Notice the contrast here getting through the avulsion, and it's bad. When you do arthroscopy on a patient like this, you probably want to do open surgery and reattach that to the glenoid instead of with the scope, because the scope doesn't get down there, and also you're putting a lot of fluid in the joint, and it gets out into the whole arm if you don't have a capsular seal. So that's a GAGL lesion. If you're looking at a coronal, I always look at the IGHL and follow it across from the humerus to the glenoid. In this case, it's not like a nice U, it's a J. And so it's off of the glenoid, and all the fluid from the joint is getting out into the soft tissues. That's an unstable lesion. That needs surgery. That is something they may not see with the scope, and the MR can really help them see it because they know they have to repair that. Now let's go to the other side. We've got the humeral side. We get the same problem, the GAGL lesion. So an avulsion of the IGHL on the humeral side will also give you a J sign the opposite direction, and it's very serious. Hard to see with the scope. We don't want to miss it. Here you can see that the IGHL is not going to the humeral neck, and it's the opposite of what we just saw. So I have the arrow pointing to it on this MR arthrogram here, and you can see how that anterior band doesn't go to the humerus. And you want to say if it's only in the front, is it in the axillary pouch? Some people just have isolated axillary pouch tears. Is it in the posterior band or the whole thing? And if you look at this case, you'll see that it goes all the way across, from front to back, like this. That is a GAGL lesion. That's a very serious GAGL lesion. So you want to pick those up. And so we had seen these early on and noticed that a lot of them actually had subscapularis tendon tears too. With more experience, I'm noticing that's not so common to see subscap tears, but do look for them and make sure that there isn't a subscap tear. And here we see in the axial view that this IGHL is not going to the humeral neck either. This is extremely rare, and about 3 weeks ago I saw one of these, so I put it in my talk, where you see this little piece of bone next to the humerus. You think that's a loose body or something. I've learned that subscap avulsions look like that, and also the avulsion of the IGHL on the humeral side called the BHAGL lesion. And so we did an MR, and we saw that it's kind of black here, it's hard to see, but it was a piece of bone, avulsed off of the humeral neck at the insertion of the inferior glenohumeral ligament, so that's a bony avulsion, a BHAGL lesion. I don't know if they're going to go in and fix it, it's old, but it's an explanation for what you're seeing there. And finally, this is extremely unstable. Hard to find a case of this. I got it from Christine Chung. But the glenoid side and the humeral side can be torn off at the same time. For the IGHL, very unstable. And so you see it here and you see it at the humeral attachment. A lot of fluid getting out. Again, a surgical lesion. I call it a flagal lesion, the floating anterior humeral ligament. Now, the bony lesions that are important are the Hill sacks and the bony Bankart. And we do want to mention them in our report and evaluate them. Here's a great article from NYU. Spiros Giftopoulos has written this, and he's writing even more now in the future about the Hill sacks lesion and the glenoid lesions. You can see that fracture that occurs with anterior dislocation. The Hill sacks we see, if you've dislocated once, about a quarter of the time people will have one. But if you have chronic dislocation, you can have it up to 90% of your patients will have it. And if you get a contusion, if you still see it, it might be a year before that goes away. So if you see one, it doesn't mean that they just had a dislocation all the time. And the other problem is that these can engage on the anterior glenoid and be quite unstable, so they may need surgery. Here we see one in the back here with some more acute contusion on T1 weighting, a defect. And when we do talk about it in our report, they're saying we should really describe how big it is and how deep it is. So the craniocaudal, the depth, and the AP dimension of the Hill sacks lesion is important. And the larger size is associated with catching, clicking, popping, and engagement. It's rare that you see a patient coming in like this, but we had one. And they're totally engaged. It's like a piece of pie in the back that got stuck on the glenoid rim. There's also deficiency of the glenoid rim in the cartilage. And they're going to have to go in surgically and take that out. And there are various formulas of what's an important engaging lesion. Larger, more vertical. Now they're coming up with a biceps angle that isn't impressed yet, but I'm sure it will be soon. So those are things to think about. And we'll be measuring those in the future, I'm sure. So what do they do for that? Well, if it's a very large Hill sacks lesion, they'll get a bone graft, augmentation about 20%. Between 20 and 40, but if it's a huge Hill sacks lesion, they might do an arthroplasty instead, especially if there's rotator cuff tears as well in older people. This is a case where you can see that this looks really nice around with 3 screws in it because they use an allograft from a cadaver. Here was the Hill sacks lesion, and they did open surgery, and then they put that piece of bone on there. It fits beautifully, and it looks wonderful. So that's one way to treat a large Hill sacks lesion, so it won't re-engage. Another way, which we're seeing a lot at our center, is what we call remplissage. We have a French group here, so to fill in is remplissage. And so you can see here how you get the engagement when the humeral head goes in front of the glenoid. Here's the infraspinatus tendon. Well, they figured out how to keep that from happening. They fill in that defect with the infraspinatus tendon, and that's the remplissage. And what it does is it makes this extra articular so that it can't go in front of the glenoid, and it's like a check ring. You don't have as much anterior instability. So here's an example of one of these Hill sacks, and then post-op, they anchored the infraspinatus tendon to the humeral head, and this was a good remplissage. I've noticed that you get a little bit of contrast going in there. That's okay, as long as the tendon's okay. So we've seen these being done. The other thing we're seeing a lot of is when they want to evaluate the glenoid rib for fractures and wear. And this is an acute injury from an anterior dislocation. It's black on MR, but it's obvious that this is not just labrum. This is glenoid rib, bony avulsion. And you can assess that with MR or CT. Lots of us use CT. The main thing is to get good 3D rendering of the fragment so that they can plan their surgery and evaluate how much of the glenoid rim is gone. But they're also showing that MR can be used for the 3D rendering. And again, the same group at NYU is doing this kind of work, showing us how we can go from a single static sagittal image to a beautiful 3D reconstruction there. So what do? Well, if it's a large fragment that's right there, they'll put it back on, just like the Hill sacks with the screw and the plate, like this one. More often, we're seeing the chronic instability that the pear-shaped glenoid, which is larger at the bottom and like a circle, can resorb over time and become like an inverted pear, very narrow at the bottom. These are unstable, and they'll augment the anterior rim at a certain point below the 3 o'clock position. It's kind of like taking a piece of pear out of the bottom of the pear, and nothing is over there to put back. So this is what it looks like on CT and MR. I'll show you in a second. It's very flat or just smaller. And so we see this in 90% of patients with recurrent instability. Here you see an MR of that patient. So you want to comment on this anterior glenoid rim, and there are lots of ways to measure that. One of the ways is to have a threshold width loss, and they say that if you have 15 to 30% of the radius of the glenoid from the center of a circle that you draw at the bottom, which is kind of an artificial way to evaluate a glenoid. If you have 4 to 9 millimeters remaining, it's significant. But if you have only 4 millimeters or less remaining from the center of the glenoid to that location, it's very significant. And a lot of these people will get surgery, but there are lots of different ways to measure that. And you can read about them. This would be somebody who needs surgery. You can see the Hill sacks. You can also see that there's wear of the glenoid that really should be going out to this point. So what are they doing? Well, in our place, they're doing the Labral, another good French name, procedure. And what that is you take the coracoid and you cut it, and you bring the conjoint tendon below, and you augment the anterior glenoid with screws with the coracoid. But one thing they do is they cut the subscapularis muscle and tendon so that you put the coracoid in between, and the inferior part of the subscapularis is like an inferior glenohumeral ligament holding it in. It does look kind of funny, and you'll see these on the radiograph. You'll see screws in the glenoid rim there. And so this is what it looks like in a diagram. It's not totally anatomic. There's a piece of coracoid there. But these tend to do pretty well. They also have Bristow procedure, which is a variant of this. And so here's what you would see on CT or MR, where you see extra bone in front of the anterior glenoid. This is a good one. It attaches to the glenoid very well. In this article by Dr. Vogler, we have a lot of scar tissue in the subscapularis, but this is doing very well. So my last slide is just showing us that you can get complications from this procedure. Like these can never heal sometimes with a non-union, or the screws can fracture like we see here. So CT is a good way to evaluate that if you ever need it. So in summary, what I've tried to do is go over the many causes of anterior shoulder instability. We can have acute dislocation, we can have chronic instability with or without dislocation, we can have subluxation, micro instability, and that anterior-inferior labrocapsular injury is very common. We have various presentations. We want to be more descriptive in our reports. That ABER positioning, in my opinion, can be quite helpful for showing those labral lesions, cartilage lesions, undersurface tears of the rotator cuff, instability of the glenohumeral joint, and that we do have those Hill sacks and Bankart lesions. If they're large enough, they get treated with surgery. And it's also very important to be familiar with the surgical procedures and the expected postoperative appearance. Thank you very much.